Welcome back. This is Mustafa Farid, and this is my YouTube channel. Today I'm gonna be talking about diseases of the arterial system. Let's get started. This is a good carpet, while this one is worn out. That's the way I want you to think about the intima of an artery. The intima is simply an upper layer of endothelium that rests on a layer of elastic tissue. Like these rolled carpets again. Atherosclerosis is simply wearing out of the arterial wall, to be more precise, the intima. The hallmark of atherosclerosis is the atherosclerotic plaque. An atherosclerotic plaque is a focal accumulation of lipids and fibrous tissue in the intima. This resembles the eye globe of Horus, an Egyptian god, in its surrounding eyeliner. Look again at the plaque in the intima. Here, intraplaque hemorrhage can be appreciated. So why do plaques form? They form owing to the continuous insults the endothelium has to take. Insults like high blood pressure, lipids, glucose, and smoking, etc. As a reaction to this, macrophages enter the intima together with lipids, where they settle down. Smooth muscle cells from the media in turn also migrate to the intima, where they release some growth factors that help deposit extracellular collagen. These growth factors also may induce some new vascularization in the plaque, which are often the reason for interplaque hemorrhage. With time, some of the macrophages and the smooth muscle cells undergo apoptosis, or in other words, programmed death. This is responsible for the known structure of the plaque, being formed of an inner core of lipids and cellular debris and an outer cover of collagen fibers, so-called the fibrous cap. The ratio of inner lipids to outer fibrous tissue vary from plaque to another. As seen here in this image, there are two plaques of the same size but totally different composition. Again, plaques everywhere. Actually a spectrum of plaques. Each one has a different composition, ranging from predominantly lipid to predominantly calcium. The important concept I want to deliver here, as we go to the side of the spectrum with the more juicy lipid core and a thinner fibrous capsule, the plaques become less stable. This means that they are prone to be torn, causing an erosion or a fissure at the arterial inner covering. This leads to aggregation of platelets and formation of thrombus that may in turn totally occlude the artery or become a source of distal embolic showers. Okay, let's see all of this in radiology. Notice here the bright inner, dark outer lines lining the wall of the artery. They are normal intima media that start thickening in atherosclerosis. Now we see a small intima echogenic plaque. This one is hypoechoic, could be due to intraplaque hemorrhage. And here, a large ugly heterogeneous plaque. Moving to angiography, that doesn't show the plaque itself, but shows its effect on the artery caliber. This image shows a severe stenosis in the ICA origin from the large ugly plaque we saw previously on ultrasound. Another example of plaque-induced vascular stenosis, this time by a circumferential plaque. So, a question here, is this plaque hemodynamically significant? In other words, does it need treatment? Well, authors in textbooks agree. If it causes above 75% stenosis, then it's hemodynamically significant. But to be honest, if it causes ischemic symptoms, like this TIA here, then it's hemodynamically significant. Another scenario, if there are successive plaques of mild to moderate grades of stenosis, they sum up and deserve to be treated. So remember, it's all about the clinical state. Okay, now we move on to another problem, mostly precipitated by atherosclerosis. It's dissection. Dissection simply is a hole in the intima, like this hole in the wall. Blood enters into the arterial wall from this hole, where it dissects it to form a second false channel. Blood in this false channel is under high pressure. The false lumen may expand to include the true arterial lumen, not to mention the arterial branches as seen here. Common carotid artery angiography shows narrowing of the ICA lumen, which tapers as it rises distally, owing to its compression by the false channel from the dissection. CT angio shows both lumens, as seen here in the ascending limb of the aortic arch. To treat a dissection, you simply have to cover the hole. This can be done by a stent, which also reestablishes the caliber of the true lumen. Thank you for listening. I think it's better to discuss the remaining arterial diseases in another lecture. Stay tuned.